One other thing to kind of go over is how are we dealing with patients who have the DNA HRR mutations, so the BRCA1, BRCA2, and many other mutations. So, Dr. Liu, I was wondering, we talked about when we're going to test and stuff, but are you using the PARPs, early on, right, during the initial phases of CRPC when you find those patients?
I think that early usage should be recommended when we have patients with BRCA1 and 2, CHEK2, ATM, because people with these mutations, which are homologous recombination repair mutations, their cells don't react the same, and they do rely on these PARP pathways. Yeah. And so I think that using an early adoption of a PARP inhibitor into their treatment algorithm may save them from trying a lot of things, other things first.
Yeah. And then a lot of the trials that were done, like the Propel, Talipro, and Magnitude, they were all doublets. And so they were combining PARP inhibitors with some of our usual agents. But all those were done in people who were relatively naive to the what we used to call novel hormonal agents. And so how are we thinking through? It's the same question as piece 3. If a man had been on, Dr. Gonzalez, I'll direct this to you. How do you do, what do you do when you have a man on ADT, ARPI, who then progresses and has a BRCA2?
I've been continuing the LHRH agonist or antagonist. I've been removing the, androgen receptor inhibitor and then adding the PARP inhibitor. Yeah. These folks come in on a regular basis and get regular blood chemistries, and watch for the toxicities. But in general, I've found them to be pretty well tolerated. Yeah. And have some impressive PSA responses as well. Yeah. I've been very pleased in the folks, particularly with the BRCA mutations.
Yeah, you mentioned toxicities. Any other toxicities, Dr. Satpute, that you see with the PARPs?
Yeah, one of the issues with all PARP inhibitors is the myelosuppression. It is sometimes very hard to navigate and manage these in those who, especially who've received the myelosuppressive therapies in the earlier setup, like chemotherapy, maybe even the radioligand therapy. So they tend to have that issue, and we have to keep adjusting the dosages. There are some remote concerns about that, such as a second malignancy, hematologic malignancies and such. So we just need to make patients aware, and they really need to watch their counts closely.
I think one of the main things is, our system and where we work, we're all in the hub, we're all in the know, we concentrate on prostate cancer, so we're all doing the genetic testing. And I think one of the things that is, very important is that everybody who touches a metastatic prostate cancer patient needs to think about genetic testing and get it done. Some of us are doing it in our offices, some of us refer to genetic counseling and genetic specialists, but, getting the genetic testing done is very important. So, well, good. Well, we've kind of.
I'm sorry. Do you like to continue the androgen receptor inhibition when you add the PARP inhibitor? Or do you pull it off?
It's a great question. So similar to that piece 3 discussion, what do you do? Do you stop ARPI and go with olaparib only, because that's kind of where it is in the PROfound study? But it's very tempting because with the Talipro 2 study, you had talazoparib plus enzalutamide, and enza is not a bad drug. We talk about certain side effects, but a lot of guys tolerate it really well. So I don't know yet, and I think I would have to just talk to a man about whether or not do they want to do just the PARP alone, or do they want the combo. I think I tend to be a little bit more aggressive as an oncologist. So it depends on the man. It depends on his disease state. Has he got high volume? Is he really? Am I worried about him? Yeah. Or has he got a more indolent, kind of like the PSA is barely going up and there's just a couple of new spots? Well, then maybe a PARP alone, But I'm not opposed to using the combo, because I would hate later on to find out some clinical trial shows, yeah, sure, you should continue it, and there's all these men who didn't. And I think it's different when your toxicities are high. So with enza, if you're doing talazoparib and enza, I just don't find it's that bad. So I would say I would be favoring that. But granted, there's no data and it's all opinion, and we all have to make a decision at some point, which is
interesting. Thank you very much.
Well, great. Well, this has been really great, guys. It's wonderful to go through prostate cancer and these diseases that we treat, and so thank you to GU Oncology Now for allowing us to do this.